Yeah. First of all, Jacques and Professor Sami right there. Thank you so much for inviting me, and I speak on Jeff's behalf as well. It's such an honor to be here today. And congrats to you for holding this excellent conference in our hometown. I know time is short, so we put together some cases for the panel. This is really more just to get an opinion as time has sort of moved on here. I have no disclosures. I'm not sure about Jeff. Oh, that's good. All right, so I'm going to present a case and then get opinions, and we'll start with Dr. Esquenazi. If you don't mind, we'll put you on the hot seat real quick. So this is a 56-year-old woman with a history of headaches for several weeks, no neurological deficits, who presents with, to clinic, outpatient clinic. So she sees me on Friday with MRI showing a right frontal mass lesion. Past history is unremarkable. When you see her, well-appearing, no acute distress, but a profoundly flat affect, although she's appropriate, and has been on steroids with slight improvement in her headache. So she has this MRI scan. So I'm wondering, if this patient walks into your clinic, what would you do?
Yeah, no, thank you. And thank you, Jacques, for the invitation. I mean, amazing talks this morning. So I'll go back to this case. So obviously, this patient has been referred to us because there's a large mass. So we're looking here. This is a post-contrast MRI of the brain, which shows a large cystic necrotic mass located in the right frontal lobe, which makes sense. She's been having the headaches and affection to judgment of some of the functions of the frontal lobe. So certainly it is very concerning. I would ask in general to make sure that she doesn't have anything else systemically going, that she hasn't had any weight loss, but in general for something like this, I don't routinely do any further imaging test of the abdomen or chest.
Perfect. So, exactly. And this lady sees you on Friday at, let's say, 3 o'clock. So
she had a seizure on Friday?
No. She sees you on Friday.
She sees me on Friday, right.
So you're heading home for the weekend, and she, wants to know, you saw her in clinic, so you just schedule her for surgery. What would you do?
Yeah, well, it depends on how she's doing. If she has a completely normal neurologic exam, I'm very concerned about this being a high-grade tumor, a high-grade glioma, and I would discuss with her that she needs resection, both to get a diagnosis, to relieve mass effect, and because we need to know what she's dealing with. If I see her in clinic and she's completely normal and she's responded to some of the steroids that she's doing, I wouldn't have a problem in scheduling the surgery for, potentially on Monday or the next week.
Yeah. So that is exactly what I did. But then, of course, on Sunday, she shows up, the ER, completely unresponsive. And over the course of the preceding 2 hours, become less and less responsive. And she's brought to the hospital. And on exam, she's now GCS4, extensor posturing. Pupils are 8 millimeters, non-reactive.
One of the concerns, obviously, I would have looked at all of the images to make sure that she doesn't have an intracranial abscess and make sure that, there's no restricted diffusion, any signs of infection.
None of that.
But it is unusual to have such deterioration unless you have an intracranial hemorrhage. Yeah. But obviously, I will get a CAT scan to see what's going on. Right. So it just looks like she just has more edema. And, there's certainly more shift. So obviously, I would take her to the operating room at that time.
So I did exactly that. Emergently took her to the operating room. And unfortunately, we took her, did a right frontal craniotomy. Post-op, got a reasonable resection. But she also has this. So she herniated. And I show this case just because I want to get opinions. I show this to the residents too, to ask them their opinion of what's the urgency of some of these things. You see people in the clinic, I think they can wait 48 hours. She's on steroids, that sort of thing. But now I have a much lower threshold for maybe admitting somebody.
Right.
I showed this case to Mitch Berger actually, and he told me that he would have admitted this patient, put him on high dose steroids, and done surgery maybe over the weekend. And I can't claim that I've seen patients like this since then. If they're intact, I still, roll the dice a little bit. But yeah, it's one of those recency bias cases where it sticks in your head. I always think about this case.
No, I mean, I've certainly seen these before. Not as dramatic as these, but typically in patients that have some form of shift and have been pre-treated with steroids for a very long time. In those cases, I would admit those patients, but I mean, this is rare for sure. So.
I think just the size of it, and I think he has a lower threshold for just bringing people to the hospital and that sort of wide awake when she saw me. Yeah.
I think in Texas, this is sort of like a medium-sized lesion that we see.
Right.
No, honestly, I mean, this is like the normal size that we always see.
Yeah.
My typical response is the only thing that changed between the day before the scan and the day after the scan is right? The symptoms are no different. You got them on steroids. This thing's been there for a lot longer than the day before the scan. So you would think that they had the month and a half beforehand to clear themselves of the emergency that happened 24 hours after they saw you.
Absolutely. Also, I was remiss in not introducing our panel. So Dr. Xu, who's a neuro-oncology at UT, Dr. Esquenazi, who's a neurosurgeon at UT, Jay-Jiguang, who is at UCSF now.
Yeah, new tumor surgeon working with Dr. Berger at UCSF. So,
right. And Dr. Rafael Leal,
a neurosurgeon from Brazil.
Brazil, perfect. Okay. So
I think the only thing that I obviously cannot speak for Dr. Berger, but now working with him, I think one thing we consider is admitting patients and also putting them on some mannitol, particularly when they have severe headaches. Obviously, you can't predict something like this would happen. I would have done it exactly as you did, but it's something we do.
That's what I came here for, was absolution. So thank you. Jeff, think that's the next.
Yeah. So I agree with Yoshua that this is we call a cystic GBM based on the imaging. I have not seen the flare MRIs. I would expect some kind of a flare, involvement of corpus callosum or genuine corpus callosum. And obviously the treatment, if it confirmed as a GBM or IDH wild type, and the standard of care is maximum safe resection, which is achieved. And then concurrent radiation with temozolomide, we call a STOOP regimen. And after finished radiation, continue cyclic temozolomide or adjuvant temozolomide. In Europe, in Canada, 6 cycles. That's the protocol of the trial from STOOP. And we usually do it for 12 months. And in addition to that, we added the TTF or tumor treating fields. Again, for how long, depend on patient tolerance or MRI appearance. I will usually do it for a year if a patient have a good compliance to that. So that's a standard care for that. And do MRI every 2 months. The first one is 4 weeks post radiation, and then every 2 months.
All right, thank you. All right, so this is a 75-year-old male from Qatar who presented. He had a couple of weeks of confusion, speech difficulty, and we're interviewing him without the AI translator, but with a real translator. And he had global aphasia, hemianopsia, right facial droop, and a right upper extremity drift. And this is the scan that he presented with.
I don't mind taking this one. So we're looking at axial T1 post-contrast images on the left and middle, and then what appears to be a flare scan on the right. There's enhancing sort of insular frontotemporal lesion, lots of non-enhancing disease, including edema, very consistent with his symptoms. Certainly concerning for a high-grade glioma, particularly with his age. So I think the big question is, obviously this needs to come out. Is his speech so poor that you can't do it awake? And so
not speaking Arabic, but the Arabic interpreter told me, don't think about doing it awake.
Okay. And honestly, this is another case that at UCSF, we would commonly admit, start on high-dose decadron and mannitol and reassess the language and see if there's any improvement. Because I think your ability, we've written a lot of these papers with the Raynaud Resect group, and you want to try to get a super total resection when possible. Obviously, you're not going to be able to get all of this flare out, but you're not going to be able to push the limits with him asleep. You're going to make him a lot worse. So,
all right. So the panel agrees.
Yeah, I mean, I would not even try to do this awake. The goal of this surgery is to, get as much tumor as possible to improve the mass effect and to remove as much of the enhancement. But if you see there's tumor going into the, the deep basal ganglia, and, there's some tumor medial to the lenticular striate artery. So I would do this with a patient asleep, and then I would start doing subcortical mapping to find out where the corticospinal tract is posteriorly on the most posterior part of the insula. But as you see, the tumor comes to the surface in the temple operculum, and you can use that window, and then you would do some transinsular window approach as well.
Dr. Leal?
Yeah, I agree. I have a question.
Yeah.
Would you do that with some kind of fluorescence to aid in the resection?
Yeah, I mean, obviously, 5-ALA fluorescence, but honestly, in this case, you're going to see much fluorescence beyond of what you can resect. If you see there in the basal ganglia, and then you're going to start seeing some of the fluorescent lighting up. And I think the benefit of the most important critical thing on this case is the mapping, the subcortical mapping for the motor pathways.
So I'm gonna save you guys a little bit because he came in and actually came in on steroids. So that was his outside scan, and this is his new scan.
Lymphoma.
Right. I mean, obviously, you need to take a look at the diffusion weighted imaging. Could this be a lymphoma? It's certainly possible. There's that, and even the initial scan, I don't know if you go back, there's a little bit of enhancement that looks like it's tracking along the MCA, not actually in the fissure. So I still think it's very concerning for a high-grade glioma, even with the response to steroids, but obviously need to look at all the sequences. It actually wouldn't dramatically change, I think, the recommendation to get tissue and proceed with it. But you can do the subcortical motor mapping awake or asleep, depending on his language, but yeah, so.
Yeah, this is suspicious of a lymphoma, and obviously the HIV status, all those staging we should do before we commit it. You probably just do a biopsy, and in the future we probably just do a CSF, NGS, and we can make a diagnosis if it's truly lymphoma.
Yeah, in this case, I would do just a biopsy to confirm diagnosis.
Yeah, so the biopsy showed CNS lymphoma. Yeah. Yeah. So how do you, what's the standard now for CNS lymphoma?
Yeah, so for primary, obviously we do the staging. It could be a primary or could be a systemic lymphoma with CNS involvement. Also the vitreous or ocular lymphoma. So those things we do at the staging, and the treatment. Let's say just a primary CNS lymphoma for the brain only. High dose methotrexate is a standard of care. Different protocols, have at least a DeAngelis protocols or MGH protocols. Everybody based on high dose methotrexate. I would do is high dose methotrexate. We do it as an inpatient. Like less pathology is give us a frozen diagnosis, suspicious for lymphoma, and waiting for final permanent. We just prepare for CNS lymphoma in terms of methotrexate treatment as an inpatient. And obviously patient on steroids, as you already know, and rituximab and temozolomide. Initially, I push the dosage to 8 grams per meter squared. I usually do the first, depending on the patient, if it's good health, I should start with maybe 4 or 6 grams per meter squared, and then if doing well, I push for 8. And it continue doing well every 2 weeks until we see a CR. Then we do it every 4 weeks, and then depending on the situation, sometimes for young people we consider autologous stem cell transplant. And still new, we don't do it in UT Health. We send to MD Anderson or Baylor or / Methodist. Now they divorced, but we send it to George Karam in Methodist to evaluate. But the patient usually reluctant to do stem cell transplant because the risk is still pretty high, like a 5% mortality rate. So patient, after the methotrexate, patient should doing well, recover to baseline, commit them to this kind of a quote unquote high risk procedure. They're usually reluctant. So I think once the autologous stem cell transplant procedure safety margin increase, I think that would be the future trend. But that's for now is our standard. And then if they still have disease, obviously whole brain radiation is part of that, but we try to postpone that to the last resort because of cognitive decline. Sometimes you treat the patient, they quote unquote in remission, you give them a dementia like 5 years later. So I don't think that's a fair trade, and so we postpone that. And then the ibrutinib or Brukinza, and those I use as optional in the future for patients if they cannot tolerate methotrexate or they still have some disease. I think that still works from anecdotal experience. Was that? That's right. We hold off on radiation.
Would you do? Oh.
You and this one's neurosurgery about doing biopsies of patients with lymphoma on steroids, and that the diagnostic yield goes down significantly.
Right.
You really got to target enhancing disease. So if I saw him like this, we would take him off steroids, probably become more solid.
2 weeks. Would you say like 2 weeks later, or what would you?
I've seen him take 3 months,
yeah,
and then usually ends up in a different part of the brain.
Right.
Yeah.
Mm-hmm.
I think we get the treatment anything if they don't have obvious.
Yeah, I agree that steroid can interfere the diagnosis.
Yeah, just a couple of things.
Not significantly. I mean, we sometimes we're treating ourselves than treating the patient in the practical sense. Not significant benefit.
And the way you're sending them
No, not intrathecal, just the standard stem cell. Yeah. George Karam in Houston and then MD Anderson folks, yeah, 2 institutions. We don't do it in our institution, but they do it.
I know they're doing it abroad globally.
Oh, of course, Germany, they do a lot of that. Yeah. Right. Right.
Couple of things on what you mentioned on the lymphoma. You know, there's the field is probably going to be evolved because in many cases, like this is nothing else rather than a lymphoma. And sometimes you see them radiographically, but unfortunately, the neuro-oncologists would not treat unless they have tissue. So with circulating tumor DNA, and there's actually a mutation called MYD88 mutation, which is present in 80% of patients with lymphoma. And probably in 3 or 5 years, we're not going to be doing biopsies for lymphomas anymore. As long as, you know, the field evolves and this becomes standard.
Let me just show one more case and we have time. Speaking about tumor or treatment evolving. So 45-year-old Indian male, no significant past medical history, traveling to New York City. On his way to the airport, has a seizure. He's taken to the emergency room, had polio as a kid, but otherwise is normal and is intact after the seizure. Well-appearing male, no acute distress. Neuroexam at this point is normal, but he gets this MRI scan. Well, just wait. just wait. It's coming. It's coming. All right. So, Jake, if you could maybe comment on that.
Yeah, sure. So, right superior frontal gyrus, we see this flare hyperintense. I don't think you would call that a T2 flare mismatch per se, but it doesn't have. I can't tell if there's very faint enhancement there.
Can you comment on the T2 flare mismatch?
Yeah, so I'd like to look at the T2 when it's very, very bright, and then on the flare, if you see it bright on the outside and darker on the inside, which it kind of has that appearance, but it's not as bright on the T2 scan, it makes you think more of a IDH mutant astrocytoma. Not that that necessarily changes my recommendation for a maximal resection in this case, but it can be helpful when you're talking to patients, and there are treatments for IDH mutant tumors, particularly.
Yes, hold your thought on that. But yes, correct. So, what would you offer this patient?
I'm a UCSF disciple. There's only one answer here. It's a maximal safe resection, and all the data supports that too. Of course, people are going to start pushing these IDH inhibitors more and more and more, but the data is not great as far as long-term. The New England Journal paper, I think, had a total of 36 months of follow-up. There's a lot of crossover in those studies, and I'd like to withhold that for as long as possible. They had a seizure. I think the answer is obvious. It's D. No questions.
So this patient was in New York, as David pointed out, on a Saturday, and got a biopsy, of course, because they wanted to make a diagnosis, and sent him on his way to Texas. So completely ridiculous. So we don't recommend this, but I do want to ask Dr. Zhu, and Jake brought this up. So in the era of IDH inhibitors now, this patient's 45, and I've drunk the Kool-Aid too of maximal surgical resection, obviously. But would there be a role for neoadjuvant IDH inhibitors before surgery, or maybe to see what happens?
I don't think so.
And this ends up being, just so you know, there was a mismatch here. It ends up being an IDH mutant.
Yeah, I would still do the maximum safe resection, and then because the inhibitor definitely give us additional armamentarium, but the tumor still grows. It's just slowing down, especially for people otherwise healthy. Eventually, they're going to develop some kind of significant impairment or encroach on the motor fibers. So you might better resect them early when they are relatively restricted or small, and then maintain that. So not to let the tumor grow with the inhibitors, along with the other chemos and with radiation. I think that's a better strategy.
So we put this patient through a right frontal lobectomy and got a reasonable resection. In the post-op setting now for an IDH1, we'll call it a grade 3 anaplastic astra. What would you recommend post-op?
Yeah, I think this is actually a controversial or debatable. If no flare signal, no T2 signal, it's really a total resection of the flare signal. There's no enhancement in the first place. So if it's grade 3, usually we do radiation But if it's grade 2, we can observe.
Patient's 45. Would you still observe?
Yeah, I know 40 is like below 40, you call a low risk, and above 40, that's obviously man-made, kind of a ballpark estimation. But I think it's really a location dependent, also the post-op flare signal dependent. If there's a flare signal present, and then obviously we know that's, could be edema, but most likely, I think it's tumor infiltration. So they would, keep growing if we just doing observation, although it's very slowly. But if you monitor closely, and sometimes a young patient that they may have had their spouse, if it's a male, pregnant. So we don't want them to expose to chemo. So we try to minimize that, we delay that. We have some patients that get their pregnant, and they have their biological tumor that's undisturbed. I think that's a better option. So we can wait for 1 or 2 years. Then we do the radiation and chemo after that. But I think it's a grade 3. Usually we do radiation and then subsequent temozolomide. Or if we have a significant disease, we just do a concurrent, like a stool protocol in radiation with temozolomide, and then followed by temozolomide.
Dr. Leal, have the IDH inhibitors made their way to Brazil yet?
No, not yet, unfortunately. No.
I think it's noon, so we may be wrapping up here, I guess. Jacques is leaving, so I guess that's a clue. Jacques, do you want us to wrap up? It's noon, I think. Yes, no, I think. Thank you very much for your discussion.